and welcome to this PrecisCa breast mini tumor board on breast cancer. My name is Dr. Reshma Matani, and I'm a breast medical oncologist and an associate professor of medicine at Sylvester Cancer Center, University of Miami, where I co-lead the breast cancer program. It's my good fortune today to be joined by several well-renowned experts in breast cancer, who I will now ask to introduce themselves. Dr. Buchholz.
Hi, my name is Tom Buchholz. I'm a radiation oncologist, professor emeritus at MD Anderson Cancer Center in Houston. I'm the medical director of Scripps MD Anderson Center in San Diego.
Terry Bauman is a breast surgical oncologist. I direct the breast cancer program at the Orlando Health Cancer Institute.
Hi, Bill Gradisher, professor of medicine and chief of HEMONC at Northwestern University in Chicago.
I am Maxine Jockelson. I'm a breast imager at Memorial Sloan Kettering Cancer Center, professor of radiology, and I also do a little bit of PET.
This is a 43-year-old woman with a history in 2019 of a right phyllodes tumor who underwent surgical excision with clear margins. More recently, she has a detection of a new finding in her right breast and undergoes surgical excision with 2.2 centimeters, again, phyllodes tumor, with tumor present at multiple margins. So before we get into the question posed on the screen, let's again review the patient presentation, her prior history of a phyllodes tumor, and the fact that the screening mammogram now demonstrates new findings, and she has a good performance status. In terms of her other medical issues, she has anxiety, hypothyroidism, and irritable bowel syndrome. GYN history, she's G2P2, no history of hormone replacement therapy, used oral contraceptives for a few years. And her family history is significant in that her paternal aunt at age 40 had breast cancer, and a maternal grandmother had breast cancer as well, a melanoma in her sister at a young age. In terms of the further history, in January of 2019, initially she had undergone a right breast surgical excision for a 5.3 centimeter phyllodes tumor, which was intermediate grade with good margins. Closest tumor edge, or the margins were that the closest tumor edge was 0.3 centimeters to the anterior margin. And more recently, in August of last year, on screening mammography, a possible mass in the right upper outer quadrant, as well as a separate area of distortion is noted. She undergoes a diagnostic mammogram and ultrasound that shows this mass is persistent, 2.2 centimeters versus a focal asymmetry. Dr. Jockelson, if you'd like to review our the screening mammography.
So we have two views of her right breast. She has very dense breast tissue, and you can see circled that there is a mass in the upper outer quadrant. In addition, she has some surgical clips in the axillary tail, and then there is an area of architectural distortion, right just superior to the mass and adjacent to the surgical clips.
So she then undergoes a bilateral MRI that shows 7 millimeters of non-mass enhancement at the site of expected distortion. The 2.2 centimeter enhancing mass is present at 9 o'clock. She undergoes 2 MR-guided biopsies. A 7 millimeter area of non-mass-like enhancement is found to be a complex sclerosing lesion. The 2.2 centimeter mass is a fibroepithelial lesion with increased stromal cellularity, and surgical excision is recommended for definitive diagnosis.
So this is just a single slice of her MRI, and it does demonstrate the mass, that is the fibroepithelial lesion. It does not have the images of the non-mass enhancement on this particular slice. So this is her post-biopsy mammogram, and basically what you can see the surgical clips from her prior surgery. You can see a biopsy marker in the mass in the upper outer quadrant, and then there is another biopsy marker in the region that had demonstrated the architectural distortion.
In November of 2020, the right surgical excision again showed the first finding was a 0.5 centimeter complex sclerosing lesion. The second area was the phyllodes tumor, intermediate grade, and multiple margins are involved. There is genetic testing that's sent given her family history, and pathologic comparison with the 2019 specimen showed that the histology was similar, but not necessarily related. So before we get into this question on the screen, given that these tumors are quite rare, will perhaps be best to start off with a discussion about some of the background information in terms of epidemiology, risk factors, and clinical presentations of these tumors. So Dr. Gradishar, can you start us off by giving us some background on these relatively uncommon tumors?
Well, these are tumors that really don't necessarily fall into the domain of medical oncology in most situations. Again, it's important that the pathologist has a good look at the material from the specimen, because we want to make sure that this indeed doesn't either contain any elements of invasive cancer, more traditional kinds of breast cancer, and that it isn't more sarcomatous-like. In the absence of those findings, we typically rely on our local therapy colleagues to manage with excision and clear margins. And I think part of the discussion is the extent of the margins, which I'm sure our colleagues will comment on. And then the issue of whether or not any other additional local therapy should be part of the plan. But for the most part, medical oncology doesn't really play a big role in the management of these patients.
Thank you. Dr. Jockelson, you reviewed the imaging findings here. Could you let us know if there are any characteristic findings on imaging for these tumors as opposed to the more common types of breast cancer?
Well, phyllodes tumors are classically more circumscribed than typical breast cancers, although triple negatives can be very circumscribed. So basically, phyllodes tumors are generally circumscribed if we have prior imaging, or the history demonstrates that they can grow very rapidly. The patient will come in and say, gee, I had a lump, and then in the last couple weeks or couple months, it's grown rapidly. In terms of the complex sclerosing lesion, there's nothing specific. It's almost an incidental finding in many situations when we're biopsying an imaging finding, and it's generally considered to be concordant with whatever we see, but there's nothing that's specific that says, oh yeah, this is a classic sclerosing lesion. It's usually just something that we find incidentally.
Mm-hmm. So Dr. Maminas, the question that was posed here was with regards to margin status. So if you could address that as well as comment on the need for any lymph node evaluation in this situation.
So typically for phyllodes tumors, you need to excise them with an adequate margin, which typically we aim for about 1 centimeter margin. Now that's not always feasible, and sometimes we accept, smaller margins, but in general, you have to have at least few millimeters, and we again aim for about 1 centimeter. Now this patient, the first time, also had a close margin, right? It was about 0.3 centimeters or 3 millimeters, if I remember correctly. So. Right. Now, whether you would have done a re-excision back then or not, I think for one focal margin, it's close. I think you can probably let it go. But now she has this other excision that shows multiple margins. So clearly, she requires re-excision with the aim again to get about a 1 centimeter margin all around. If that's not feasible, or cosmetically that will leave the breast not looking, like a breast, then obviously the option of mastectomy can be discussed with the patient as well, given that it's a recurrent phyllodes.
And Dr. Buchholz, could you talk to us about indications for radiation in this situation?
Yeah, unlike traditional epithelial breast cancers where radiation has been established to play an important role in breast conservation, for benign phyllodes tumors, we rarely use radiation, rely on surgical therapy as upfront. One of the most important distinctions of phyllodes tumor is to determine its grade, or they're categorized frequently as benign phyllodes or borderline phyllodes or malignant phyllodes. And sometimes in the setting of malignant phyllodes, we treat them very analogous to a sarcoma, and radiation may play a role depending on the particular circumstances of it. But for benign phyllodes, like this particular case, radiation rarely has any role to play.
Thank you.
Just to add, you asked me and I forgot to mention that there is really no role for lymph node assessment, because these tumors, even in the malignant case, behave more like a sarcoma. They don't involve the nodes, but benign phyllodes tumors, no need to do any axillary assessment at that point.
And Dr. Gradishar, I think you already addressed this, but I'll just ask you to reiterate any role for systemic therapy in a situation like this.
Not for this. I mean, there are, for those that really have sarcomatous elements, you know, there are small series that have looked at the use of adjuvant chemotherapy, but I think for the most part, the data is less than compelling, and we really don't have a role in these kind of tumors to play.
So in conclusion, the panel concludes that for this particular case, the margin status should be ideally a centimeter. There's no role for lymph node evaluation, no role for any adjuvant systemic therapy or radiation.